And Thomas, you know, I don't do anymore that kind of surgery because Peter is doing very well. But I'm surprised that you don't, when you talk about impingement, so on the diagnosis, in terms of diagnosis and treatment, you don't mention the soft tissue impingement. So does it exist? Still exist? How do you see that, and how do you do? How you rule out this soft tissue impingement if it exists?
So I only had 50 minutes, so that's I focus on bony impingement. But to be honest, for me, when I look back, I think there's only soft tissue impingement. You can even have osteophytes, but it's always the soft tissue which gives the symptoms. So to be honest, you can skip away the bony impingement. It's always soft tissue, to my opinion.
This is very interesting.
I totally agree with Jonas. In fact, bony impingement. When you see the osteophyte, you are very happy because you say it's clearly the localization of the pain, and you can palpate the osteophyte. You remove it, but we can see that after 5 years there is the same osteophyte. But what changed in between the before surgery and after surgery that we removed the synovitis, scar tissues, and that to my mind that's what is painful. No, and that is impinged in between or not in between the osteophyte, and that is painful. So you have to remove to make a big cleaning of the soft tissues.
I fully agree. I think only the osteophytes, then the anterior joint space, which was shown before. When you have osteophytes in that anterior joint space, you have a higher chance of a soft tissue impingement. So that's why you probably remove it.
Yeah, I was looking at the data you've got on anterior impingement, the bony impingement. Is there anything difference between left and right-footed soccer players, and if it is the ball that's the impact that's causing it, why do we get that in ballet dancers? And also, we mainly see it on the tibia. There's probably lesser on the talus. Do you think there's a difference there?
Probably you know something about Dutch football. We train them both legs.
That's why we lose at the moment.
And what you see, it's more prominent in the prominent leg where they play with, and especially when they had an injury before. And we know from, I think, Exton's work, there's a higher chance of an injury on your most prominent leg where you kick with. So probably that's a combination. And ballet dancers, probably you've got more experience with them than me.
Microphone, please.
I would like to ask Dr. Peter, when you do posterior subtalar fusion arthroscopically, do you do any traction, or do you need to open the joint, or just you?
So the technical note on that is that you use the classic two portals posterior arthroscopy just to enter the subtalar joint. And the subtalar joint is really hard to distract. So the distraction tools from outside are insufficient. The only thing you can do is have an accessory portal, a third portal, from the sinus tarsi coming from anterior into that region with your tool, an arthroscopic tool of 4 millimeter, 4.5 millimeter, that we use to enter a normal portal. We can use that one to really go into the joint. It's the Van Dyck technique, by the way. It's not my technique. But to enter the joint and to distract it. In this way, you can go from the lateral side first, then distract to the medial side, and in these two ways, you can really delaminate in the whole posterior facet. So there is a third portal coming from the sinus tarsi.
Peter, sorry, hogging it. There was a lovely talk on posterior ankle impingement. Can I ask you, in some patients who have soft tissue posterior ankle impingement, do you ever find there's an element of instability, so that they're getting an anterior or posterior glide of the talus that's causing that impingement? And do you deal with that if you're dealing with posterior ankle impingement?
Well, it's really interesting that you say it, because with Ashton, we are now thinking about it, and it's a hypothesis that we have. We tend to believe, because there's no real data, in my opinion, we tend to believe it has nothing to do with the subtalar joint. We do believe that it has something to do with chronic lateral ankle instability. And we are now talking, we just finished, it's Ashton, his project, but we talked about it a lot. And we tend to believe that there's a hypothesis that instability increases the posterior impingement. Yeah. So we're working on it. Yeah. So perhaps we can talk with Jay on that, because the way of moving into these phases of gait might be of help also to have a better idea on what is the trigger, what's the chicken and the egg. We really would like to know that.
Could I congratulations for topics that are fantastic, especially these young surgeons who are pushing arthroscopy, and technically that's fantastic. But what I don't understand is why these people don't have the pain after. And because you took your osteophyte, because you took out this soft tissue, that revolution started at 2000, as I understand it, with this arthroscopy. And there is one thing that is bothering me all the time. The worst thing for the surgeon is the long looking of his patient. And 10, 15 years, that comes also. How you explain that they don't have a pain? And how long this pain is going to stay like this?
Who is in charge of this simple answer?
So they have pain, but the biggest advantage is the functional recovery. And if you do the minimal invasive strategy by arthroscopy, you combine it with quick rehabilitation, with no muscle loss, with very little swelling due to the 2 days of cryocuff that they get with icing therapy, we can show images like these. They're not all like these, but we tend to have that evolution in what we see in the clinical daily life, especially for the posterior. I have personally the impression that the anteriors need a little bit more time before they really recover towards full functional well-being.
Yes, surely. I think for good indication of posterior ankle impingement, arthroscopic treatment have faster recovery probably than anterior ankle impingement after arthroscopy.
By the way, what are the outcome of this after this kind of surgery? So in practice, after an anterior impingement treatment and after a posterior impingement treatment, bony, if we can call that a bony impingement, when do you think that we can hope that the patient, the athlete, can go back to play in football, for example?
I don't have experience of high athletes, but before 1 month it's impossible to do something, because you have to, in my practice, to keep cool, to make self-rehabilitation, to avoid big inflammatory reaction. And after 1 month, you have half of the patient with quite complete relief of the symptoms, so you can begin for the training, and half of the patient with perhaps 2 months more to be careful. I don't know for your experience.
Hans, for example, for the anterior impingement, or Peter as well, when a patient asks the question, okay, doctor, you will do my arthroscopy, or not, Peter will do arthroscopy, so when can I plan my return to sport?
Yeah, I think between 6 and 7 weeks. And what's important with these anterior ankle impingement patients, you have to tell them that they only have a reduction of pain, because a lot of players in their head is that they have dorsiflexion both sides the same, and they focus on that, but that will never be the same. Also not after 2 years.
And
so
Peter,
focus on the pain.
Yeah, sorry. Peter, for the posterior impingement?
For posterior, it's between 4 and 6 weeks.
Yeah.
But again, it's a technique that is evolving. We don't have real long-term data since the technique has started in 2000. The indications are now 6, 7 years out there. So we're really working on data to be credible in our words. But We all have the same feeling, posterior between 4 and 6, and anterior between 6 and 7.
Yeah. And before if there is no other question to Pao. How I would say because we don't have any idea about the percentage of anatomical variations, and you should know that better than us, of course. How the anatomical variation can, I would say, trap the arthroscopist?
I think there are many anatomical variations. I think in all the ligaments is different studies, tibiofibular, talofibular, 2 bundles. The radiologist explained today 4 bundles of talofibular. I never see 4 bundles.
And in terms of nerve and vessels, which are the main concern in complications?
Nerves, I think it's impossible the surgeons know the anatomical variations of the nerves, but it's many kind of variations. The most important, for example, is the technique, the most frequent area. The vessels is only few anatomical variations, especially in the anterior tibial anterior artery. It's a 5%, but sometimes some authors recommend to make echodoppler before surgery in order to avoid anatomical variations in the trachete. I think it's important to think about the anatomical variations.
Last question.
Yes. Actually, Dr. Thomas, what my experience, rehabilitation after the surgery, either arthroscopy or removal the chip bone or that, it takes me 4 to 5 months just to recover for the players. But whether you have any approach like rehabilitation after the surgery, arthroscopy, can you do within 6 weeks or 8 weeks? And how you are doing within 6 to 8 weeks? And this for anatomical point, whether there is any like healing process takes within 6 weeks or 8 weeks?
So your remark, in your experience?
My experience
is 4 or 5 months to go back?
4 or 5 months to recover. And
for what? For what?
For the anterior or posterior.
After arthroscopic
arthroscopic removal, yes. But
I think it's long, no?
Some patients have a lot of time for recovery, but after anterior ankle impingement, the first month is to keep cool, and after 1 month or 1 month and a half, most of the patients have a good recovery. They are walking, they are beginning to run if they are not painful. Of course, there are some patients with stiffness, big inflammatory reaction, but it's not all the cases, of course.
And James Caldera, maybe an answer.
Sorry, do you mind if I interfere? It comes down to your rehab. That's what it's got to come down to. Because I tell you, no, can I just finish? We have a paper published on Premiership, La Liga, and Championship soccer players, looking at the results, and it is 4 to 6 weeks, about 6 weeks on average. We had a few players back earlier than that, but then there's another one coming out on ballerinas that take a lot longer. But if you do it open, it takes a lot longer. And I think the arthroscopic techniques, I'm sure that Nick's developed, are so superior. But you're reliant upon really early physiotherapy. So they get physiotherapy from 48 hours after the operation. And they sit there, I tell them to move the big toe when they wake up. And I think that, that's just what Nick was saying. And I believe Nick. It depends slightly perhaps on whether it's bony or whether it's soft tissue. But I'm sure that Nick's right.
So unfortunately, we have to stop the discussion because we need time for the break, 10 minutes, and then next session. I could say, please.